J'ai trop chaud, on n'a pas la clim.
Okay, hello everybody.
Hello everybody, good afternoon everyone, and welcome to our last webinar session. My name is Ingrid.
For this summer.
For this summer, I'll get back to you later on. My name is Ingrid and I'm the Administrative Director at Swiss Medical Gate. Hola. Let me introduce you shortly our company before starting with the doctor's presentation. Swiss Medical Gate is an international medical center and we are located in Geneva. We are working exclusively with Swiss leading medical experts, well-known professors, doctors, and Swiss leading medical institutions such as University Hospital in Geneva, in Lausanne, and Zurich, but also with private hospital who offers the same services as the teaching hospital. As you may know, we work mostly with medical travel partners all around the world, and we thank you to be one of them.
Now we need to find a place for you.
How do we work? We work as a medical coordination. We coordinate medical services and if necessary, also the administrative formalities for the patient and their families. We are your contact and we act as your partner like a bridge between you, your client, and the medical institution in Switzerland.
A pizza, yes.
Should you need a transfer, a translation, an hotel, or anything else, Swiss Medical Gate will arrange it for you. But most of all, we are here to find and organize the best medical treatment chosen by the patient. We are here to help you from your medical demand to the departure of the patient, and we do our best to give the quality service required. Now, talking about the webinar, we would like to inform you that it is conducted in English and in Russian as well. For the Russian-speaking participant, we have a Russian room, and if you wish to join this room, our webmaster Alexander will explain this to you right now. Alexander.
Уважаемые коллеги, партнеры, добрый день. Кто не знает, меня зовут Александр, и я осуществляю техническое сопровождение вебинара. По всем техническим вопросам на вебинаре у вас не работает звук, не работает видео, смело пишите в чат, постараюсь оперативно вам помочь. Так же, как уже сказал Ингрид, концепция вебинара подразумевает наличие русской комнаты и переводчика. Поэтому всех желающих слушать презентации врачей на русском языке я прошу в чате написать «Хочу в русскую комнату», я вас перемещу. Также убедительная просьба на время всего семинара выключить свои микрофоны. Спасибо.
We also would like to inform you that the webinar is recorded. And the following weeks, sometime during July actually, we will also have our own channel on YouTube that everyone will be able to watch in their own language. Nevertheless, please, we have two recommendations for you during the webinar. We kindly ask you, as you did most of you already, to turn off the microphone and also your camera. Regarding the question, you have actually two solutions. Either you send them via chat during the presentation of the doctor and they will be answered at the end of it. Otherwise, you can just ask our webmaster to speak directly to the doctor if you prefer that solution. Today, our doctor will present you regenerative surgery and dermatology. And I will leave you for now with Dr. MODARRESSI Ali, and we'll come back to you later on. Thank you. Dr. MODARRESSI, it's your turn.
Yeah, perfect. So good morning, everybody. Do you see my screen?
Yes, we do.
Perfect. So thanks a lot, Marina and Ingrid, to give me the opportunity to present you the regenerative surgery. That's a new word, and what we would do for near future. As you know, actually, when you have a wound, the first thing we do, we just leave it, and by wound healing, there is repair. When you have a repair of this wound by nature, by wound healing, you have always a scar that remains over there. Sometimes you cannot close this wound just by by wound healing process, and you need to take some part of the body and to add it to this wound to close it, what we say a flap or a graft. This leave also some scar in the wound, but also a scar somewhere else in the body. So what's new, what we can do today is just do some regeneration. What does it mean? It means we can use some regenerative elements like cells or other product, and we add to the wound, and hopefully we want to regenerate this wound and to close this wound. So what we use today to regenerate these stem cells that are defined by the cells that they have the capacity to proliferate, to give more cells, and most of them, what they do, they can differentiate. If you take the stem cell from the bone, it can differentiate to different tissue. But what's interesting with stem cells is not only the differentiation capacity, but it's also the immunomodulatory effect. They can make some modulation of immune reaction. It could be interesting for autoimmune disease. They have also antimicrobial activity, have an infection, they can kill bacteria, and they have a paracrine effect. It means that they secrete some product, some regeneration proteins that can regenerate the tissue around them. And the interesting thing is that if you just inject it somewhere in the body, those stem cells, they know where to go. They know where to go to repair on the body. If you put it in a vessel, they know they have to go to repair in a wound somewhere else. So thanks to all of those advantages of stem cells, we can use it from different tissue. We can use from bone marrow. You know, historically, bone marrow is the main donor site for stem cells. But what's interesting, we know that we can have also stem cells from embryo, placenta, and umbilicus. And the most interesting thing is that today we know all adult cells, they have adult tissue, they have stem cells. You can take a piece of skin, you find stem cells. You take from blood, you will have stem cells. From dental pulp, you will have stem cells, and also from the fat tissue. So what's interesting today, all of those adult stem cells could be from the patient himself. So it will be completely autologous. You take from the patient and you inject back to the patient, so there is no risk. For those from embryo and placenta umbilicus, you cannot use from the same patient. It should come from other patient. So today, in regenerative surgery and for aesthetic surgery or aesthetic medicine, we don't use all of those, we use some of those. And mainly, we use fat tissue. Why fat tissue? Because what you do when you do liposuction and you take 1 ml, 1 milliliter of fat tissue, you have more than 400,000 stem cells. It's 1,000 times more than the bone marrow. So if each time patient they do liposuction, you put in the garbage a lot of stem cells that we don't use. So the main advantage of fat tissue is the fact they are very rich on stem cells. The second advantage is that a lot of patients, they have a lot of fat tissue. They want to give it. They want to give to all people all the world. So when you ask a patient if you want to give fat tissue for the laboratory, for experiment, a lot of patients, they want just give their fat tissue, and the harvesting of fat tissue is very simple because just by liposuction, you can harvest the fat. You know, for the bone marrow, it could be painful. It should be a surgery, all those, but with fat tissue, harvesting is very simple. So fat tissue have a lot of stem cells. They are abundant. A lot of patients, they have it, and harvesting is simple. And finally, when you put those in the dish for have proliferation, the proliferation rate is higher with the stem cells from fat tissue than bone marrow. In Time magazine, they said that the fat stem cells is the best innovation of the 50 years, over 50 years. And that's true. And you see in the PubMed, if you're looking at the publications, there's a lot of publications, very few in 2000, but now you have more and more publications, scientific publications in stem cells. In which kind of demand in field they are published. Mainly for osteoarticular, for arthrosis, bone problem. You could use it for wound healing. You can use it also for cardiovascular disease, for brain and nerves, and others. And you see others, there is increased number of publication and use. And what's included in others is aesthetic reconstructive surgery. So how we do the harvesting and how we prepare all those? First of all, from the patient, we do just a fat harvesting by liposuction. We don't use any machine. It's a manual fat harvesting. This fat tissue has a lot of different cells. So we can purify those adipose tissue, and then after you will have stromal vascular fraction. Very interesting product, but this is not stem cells. 5% of those are stem cells. To have the stem cells, you have to put it in a dish and make a culture. And when you have a culture, then after you have the adipose-derived stem cells that you can administer back to the patient. So it comes to the patient, you do some manipulation and proliferation, and you go back to the patient. It should be very safe. And it's very safe. You use a safe technique with the safe people, because this procedure could be dangerous with infection risk, all of those, if it's not have been done well. So as I told you, you need also authorization, because this is not a real graft, it's like a drug. So we should have a Swiss medic. Swiss medic is like a FDA. FDA is for the United States to use the drugs. Swiss medic is for Switzerland. So we have the capacity, we have a protocol to produce the stem cells with different quality control to be sent back to the patient. So that's with Swiss medic authorization. The question is what we can do with those. We can do wound healing. We can use for neurological disease. We can use it for sclerodermia. You know, sclerodermia patient, they have some fibrotic tissue on the hand or around the mouth. So you can inject those products to make antifibrotic product. You can use for arthrosis. You can use for fistula. You can use for autoimmune disease. And we can add it also to lipofilling. When you take fat from some people to inject it back to other, you can improve the quality of lipofilling by adding some stem cells. And finally, it could have a lot of indications for rejuvenation, skin rejuvenation. What's the perspective of those stem cells? One interesting thing is that we can produce, thanks to the technology, evolution of technology, we can put those stem cells like an ink in a machine, and we can print different tissue, ears, nose, even we can do skin, and also areola with nipple that we can use for the patient after breast cancer treatment who needed mastectomy. And in the future, we want to do a whole tissue. But the problem with the whole tissue is the vascularization. We need some vessels to come inside. So that's why we work with some colleagues in Belgium. And what we can see in Belgium is that they take tissue. Sorry, I just closed the window. Sorry. So what they do, they take tissue from a patient. They take off cells. Do you hear me?
Yes.
Yes. So you take the tissue from patient, a face or a finger, you take off all the cells, so you don't have any immunological reaction, but you keep only vessels. So here you can see a tissue of a patient without any cells from the donor, and you put vessels and you will see that the tissue will have a bleeding, and you can put back those to the patient. So all of those is actually in the laboratory. We don't use it yet in clinic, but that could be very interesting for the future for transplantation. Even for a finger, if you want to have a finger from a cadaver, you can take just the finger, And then after, you can make a whole finger that you put over the vessel, and you can transplant without needing to have any immunology problem to have to reduce the rejection because there is no cells. So what's the potential clinical application? There's two different kinds of application. The first type is cell therapy. It means we use just stem cells and nothing else. We just stem cells for cancer treatment, for liver disease like fibrosis. You can use for a diabetic patient. You can also use some groups, I don't do, but some other they do for Alzheimer treatment, after a cardiac attack, and even for the knee pain or also hip pain. You can use those stem cells like cell therapy. What I do mostly is for skin regeneration. You can just inject the stem cells under the skin to improve the quality of the skin by rejuvenating different tissue over time. The other way to use those stem cells is tissue engineering. You need stem cells and a scaffold. So you mix those together, and what you can do ear, you can do skin, vessels, and also bone, ears, even esophagus and cardiac valve. So all of those, actually most are in clinical trial. There is not what we use every day, but I believe in next few years that will be a lot of use of those techniques. I hope that the resume was enough clear that what we can do with stem cells. I practice plastic reconstructive aesthetic surgery. So those could be used for patients who need a reconstruction after cancer treatment, but also for aesthetic cases, it could be used for those stem cells. I'm happy to have to keep any question.
Thank you, Dr. MODARRESSI. It was very interesting. I don't think there is any question, but actually I would like Marina to double check on the chat because it's mostly in Russian. So I don't want to I just want to make sure that we're not missing anyone.
No, it's okay. No questions for the moment.
There is no question. Okay.
No.
Well, in this case, we
will.
We'll just finish with the presentation of Dr. MODARRESSI. If you can just remove it from the screen, and we'll leave the word to Dr. Salomon.
Hello, thank you to Medical Gate, to Swiss Medical Gate to organize this webinar. It's a new exercise. One small problem, do you have the presentation or not on your screen?
I can try to do it for you. Let me just have one second. I can do it. Hold on a second. I'll check.
Okay, it's there. It's okay.
Dr. Salomon, is that the one you're looking for?
Yes.
Well, you just have to let me know when I have to go ahead.
No, it's also on my screen.
Oh, okay, so
I'll stop it. And everything is okay.
Okay, I'll stop it then.
It was on my screen.
Oh, so you need mine then. Okay, so I'll carry on, and you let me know when I have to change page.
Next. Okay.
D'accord, ok.
Oui, Florian, on s'est organisé. Madame va passer les dias. Pas de problème, ça marche. Sur cette forme-là, ça marche. Non, on va faire next et c'est bon. Pas de souci. OK? Merci. So, sorry. Thanks again to Swiss Medical Gate. For me, it's a new exercise. I really appreciate the presentation of my colleagues. I know the great job he is doing, and he's speaking about the future. I will speak about the past and some very common things in dermatology, which is skin carcinoma and the way we can take care of this lesion, which are very, very common, not dangerous in terms of health, but in terms of morbidity, it can be very severe. On the first slide, you have 3 obvious skin carcinoma. 2 are very easy to diagnose. 1 is more difficult to identify, And that's the problem that we are confronted with. Next, please.
Лен, ты знаешь, что вот только только сейчас немножко, у нас же 10 суток, и только сейчас немножко.
Ingrid, you can,
Sure.
you hear me? Next slide.
I hear you, but I'm trying to push the next one, but on my side, it seems that, is that correct?
Yes, it's okay. It's okay. So skin carcinoma is the most frequent human cancer. And in the field of skin carcinoma, the one which is the most frequent is basal cell carcinoma. The two other ones are squamous cell and adnexal cell carcinoma. Basal cell carcinoma is around 80% of the skin carcinoma we are confronted from. Next slide. There is risk factor for this lesion. The first one is age. The second one is the phototype. So clear skin is more prone to have skin carcinoma and basal cell carcinoma. But for example, basal cell carcinoma is also observed in Asian or African people. And a genetic background, we know mutations that induce or increase the risk of basal cell carcinoma. It's had to be seen as an aging abnormality in the process of epithelium renewing. Next. The main difficulties are diagnosis and mainly the limit of the lesions. As you see on these 3 different lesions, it's quite obvious to realize that it's abnormal, but the limits of this basal cell carcinoma are not easy to identify. And the reason for this discussion is the technique that we can use to be sure to remove all this skin carcinoma. Next. So we have very simple things like lens, magnification lens, we call it dermatoscope, and we have vision like with the microscope. The near future, next, is this kind of technology, which is already on the market, and it's like a microscope that you put on your skin. Next. And on this section, you can see nodules, which are the nodules of the skin carcinoma. So we have now different technology to analyze the limit of this lesion on the skin before the surgery. Next. But in the treatment, as I told you, surgery is the gold standard. We have other possibility depending the localization, the age, and the subtypes of basal cell carcinoma. For example, for this gentleman, he has 2 lesions on area where surgery is obviously the best one. Next. But again, the difficulties for the surgeon is the margin. On this lesion, the clinical margin are here. The surgical margins are here, 1 centimeter around, and the anatomical margin take all the eyebrows. So it's already a large surgery, and there is an absolutely necessity to be sure that everything has been removed at the end of the surgery. For this, we have the micrographic surgery, and it's the purpose of the talk also to explain to you what is micrographic surgery. We have frozen extemporaneous examination on some areas during the surgery, or a surgery with multi-steps. A first one, for example, like this, and then you wait around 2 days to have the histological margin and doing a second surgery. The most efficient is obviously the micrographic surgery, and I will rapidly explain to you how micrographic surgery is going on. Next. So it's Mohs micrographic surgery. Mohs is a surgeon in the 30s, And he developed the first concept of controlling all the margin of the examination piece by horizontal section. With improvement of cryotechnology, cryosection has been put in this technology in the 50s, and from the beginning of the 60s, it is used first in US and now all over the world. And so we do cryosection of small piece of abnormal skin, and we check with the microscope how this section is, and I will show you this. Next. Here, if you have a basal cell carcinoma, it has been removed with a limited margin, colored, frozen, cryosectioned, and horizontal section as made from the bottom of the piece to the top with around between 20 and 100 section, and you can easily see here in black the limit of your basal cell carcinoma. Next. Second example, you see the lesion, you remove it. In blue, you have the invisible part of the carcinoma under the skin. So your first section is in the carcinoma. Next. Sorry, Ingrid, next. You color, you do the section. Next. You have the section under your microscope. Next. And if you take a high magnification of the section, you can see the basal cell carcinoma in violet. And you see here that there is a small piece of the carcinoma in contact with the edge of the section. It means that in this area, you are not in the safe tissue, in the normal tissue. Then you continue the process. All the surgical process, all this process histologically take around 20 minutes. So the first step is around 20 minutes surgery, 20 minutes histology, and you go on with the process if you are not in safe tissue, in normal tissue. Next. So for this example, there is a second step around, and the first one here, and at the end, you have this loss of substance, and you can start the reconstruction. But you are in a situation where you are sure that no more basal cell carcinoma residue is present. Next. It's really devoid to specific criteria. The most important one are recurrence of BCC, basal cell carcinoma, after radiotherapy. If the reconstruction need a complex surgery with flaps, with certain subtypes of this kind of lesion like the sclerodermiform or micronodular, if after a first excision there is in the depth of the tissue presence of carcinoma and some risky area like the one that you see on this cartoon, what you have to know is the majority of BCC are on the face, and on the face, the majority are around the nose and then the eyelids. Next. So just two examples. For this woman, there is very small lesions that have been treated many times with cryotherapy without any diagnosis. Next. When we start the surgery, we just remove this, and the histology reveals, we call it the scleroderma or morpheoform form, which is generally very extensive under the skin. Next. And as you can see, there is a large extension around. So in multi-steps, we have removed all the lesions. Next. And the reconstruction is made with just a graft and a small flaps, and it's after 2 years. Next. After 2 years, this woman knows the story, and she realized that she has a small pimples here. She comes immediately. It's very limited. It was also a basal cell carcinoma, but as in the contrary of the first time, the reaction was immediate, and it's a very simple surgery. Next. With just a simple suture just after the surgery. Next. The second example, it's an extensive recurrence after radiotherapy. Sorry, the slides are in French. Next. And the extension is quite large. Next. It's also a sclerodermiform lesion, so these aggressive subtypes. Next. And at the end, there is a large piece of skin that have been removed. Next. With the reconstruction. Next. So in conclusion, basal cell carcinoma is very common. The surgery are the main treatment for the basal cell carcinoma, and depending the lesion, their presence and their aggressivity, we use the micrographic surgery, which has a very low recurrence rate. Sorry, a very low recurrence rate for primary BCC. And even if it's a first recurrence, we have a low recurrence rate with this technology. The only point is to respect the criteria before taking patient for this kind of surgery. So, well, so thank you very much for your attention, and we can discuss if you want this this subject.
Ingrid?
Thank you, Dr. Salomon. It seems that there is some question, but actually, Marine, I will ask your help if there is any question for Dr. Salomon, because I receive in between question on my telephone, but there are regarding Dr. MODARRESSI. So I'll finish with Dr. Salomon. I don't know if there is any question, and then I'll go back to Dr. MODARRESSI.
I don't have any questions actually for Dr. Salomon.
Okay, so Dr. MODARRESSI, if you don't mind, I will try to do my best to make it clear, because it was difficult to follow. I have a question, someone called Marina. It says, how many days do you need to come for such treatment, taking into account the time for cell growth?
Very good question. So usually if you need, if you want to use stem cells, you need cell culture. And usually you have to wait between 7 to 10 days to have the cells culture. So you have to 2 weeks.
Okay, thank you. Then there is another question from Julia. She's just asking, what about old fractures?
Old fractures. So the thing is, it depends what does it mean old fractures. It's bone fractures, and there is, I saw the question, but it's very difficult to understand what the thing is. But
Julia, either you can just speak if you like, or just add some more. Okay, yeah, she's saying old fracture. Oh, yes. Go ahead.
Hello. Yes, I was interested. Is it possible to use stem cells or the technology in treating of old fractures of bones? Yes, of course.
Yeah, but no, I mean, what do you mean old fracture? I mean, the fracture is not healed, or is a fracture that's healed? What?
Yeah.
The fracture is a chronic fracture. Yeah.
Right.
Yeah. So there is some studies. I don't do, but I know some people in Belgium. They inject stem cells in the bed in the middle of the wound, in the middle of the fracture, and this could help to close the bone. Did I answer your question?
Julia?
Yes, okay, thank you. Thank you. So
there is one, you have something else, Julia?
No, so the medicine is going ahead, so probably we will be able to have a new leg. Thank you.
Done.
And I have a question as well from Anan Gewefel. Sorry if I'm doing it wrong. Sorry, where is the question? I think it was joint, additional question about success in treatment of joint problems.
Yeah, today I think the stem cells and even the other regenerative medicine and surgery, they are good for the patient who has a small lesion in the knee or in the hip and it's painful. And by injecting stem cells or the stromal vascular fracture, we could improve the pain. It doesn't replace a prosthesis. If a patient needs a prosthesis, the patient needs it today. Maybe later we can replace prosthesis. But for the people who are young people who do a lot of sport, like Federer, all of those, they have all had stem cells treatment in the knee because the downtime is very short and the treatment is not very difficult. So these small lesions in the knee and hip with small pain, I think is a good indication.
And there is one more question from Natalia. Does stem cell activity depend on the age of the patient?
That's a very good question. There's a lot of study about the age and the efficacy of stem cells. The thing is that today we know the people, older people, they have less stem cells. It means maybe a young person has 400,000 stem cells per milliliter. An older one will have 100,000. So for the treatment, maybe the old people, they need longer time of cell proliferation. But when you have the same number, the activity would be the same for old and young people. So the number will be different of stem cells, but not the real activity per cell.
Okay, then someone is asking for the price. It doesn't say much actually. They say about the neck and the face.
Yeah. For the price, it depends always on the indications and what we want to do, what the patient they want to have, and what we can offer them. So the procedure just to prepare stem cells is at least for around the 5,000 euro.
For the face, you said, for the whole face.
Face and
neck.
For any indication to prepare stem cells is 5,000, and then after it depends. It depends if you have a lot of wrinkles, you have small wrinkles, if you want to improve just the quality of skin, or you want to fill it up, and then after you have to add the other procedure up to this. But the technical part of the procedure is around 5,000.
Okay, thank you.
One comment that Ali knows very well. If you do this, you really improve the quality of your skin. This technology is really improving the quality and the trophicity of the skin.
It's not a volumeter. It doesn't give you volume. If you want to have volume, you have to add stem cells with fat or with other product. If you want just to improve the quality of skin, as Dr. Salomon said, just to have more hydration, a thicker skin, that's a good indication, just have an injection, but it doesn't give you real volume.
Well, in case you need fat, actually just ask me. I have plenty to give away.
I told you that's the advantage of taking from the fat. Everybody has, me too, but no one wants to have my fat.
Well, never mind. At least we've tried. There's one more question. How often one have to repeat this procedure for the skin?
I mean, any rejuvenation treatment needs to be repeated. You know, even you do a facelift, after some times the skin drop again. You don't have a definitive result.
Of course.
So usually the stem cells treatment is like a mesotherapy. Maybe you need to do twice or 3 times, but again, it depends on the indications. And there is not a general answer to it, but for example, for hair transplant or hair, we know that in the hair you have the cycle of the hair. You need to have at least 3 injections at 1 month of, you have to wait 1 month between the treatment, because that's depend on the cycle of the hair grow.
Mm-hmm. Okay, well, I think that's, oh no, one more question. Is it painful?
It's
the facelift. Facelift, is it painful?
But I mean, facelift is painful. I mean, the indication for facelift is that when the skin drop. Mm-hmm. So with facelift, we just push up and we put tension. So after the operation, you will feel some tension, and that's good. It means that you paid for something that you want to have. So, but it's not really painful. It's bothering, it's swelling, you have ecchymosis, but it's not painful. But you will feel tension because you push it up and then you feel this tension. The same for abdominoplasty. Abdominoplasty, you take off the skin, you put tension, you feel the tension. If you don't feel tension, it was not operated enough.
Okay, thank you. Is there any more question? Are we clear with those doctors? Anyone else has anything to say, to add, to ask? Marina, do you have anything else on your side?
No.
Okay. No. Okay. Well, then in this case, I would love to say a big thank you to Dr. MODARRESSI, and Dr. Salomon. Thank you very much for your presentation. And I would like to inform you that this is actually our last webinar of the season, but we will come back to you in September, hopefully, and we hope to see you at this time. Until then, we wish you a pleasant summer, a good health, and we hope to see you back in September. I will leave the final words to Marina, our Managing Director. And once again, I would like to thank you very much for your warm participation during all this webinar series.
Уважаемые коллеги, друзья, большое спасибо за участие в наших семинарах. Как сказала Ингрид, мы заканчиваем нашу первую сессию и вернемся к вам в сентябре с новыми интересными семинарами. Будем рады вас видеть. Желаю вам всем здоровья и всего наилучшего. До скорых встреч. Thank you very much, Doctor.
Thank you.
Yeah, it was very interesting, and I hope to see you in September once again. Thank you very much.
Thanks.
Thank you very much for organization.
Everyone.
Thank you, Alexander. Thank you, Alexandra, our translator.
Thank you. Have a great day. Thanks.
Thank
Bye.
you. Bye.
Goodbye.